Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, we're doing another Kahoot, and we're going to be going over the care of the patient with Cushing's disease. Now, before we get started, as always, I'm going to ask you to please support me and support this channel by liking this video. You're going to love it, so go ahead and give it a thumbs up now. Subscribe to my channel if you haven't done so already, and don't forget I'm now offering a next generation NCLEX reviews, part 1 and part 2. If you're a current nursing student, you're not studying for boards, you're just trying to survive the actual program, I have plenty of audio lessons available to help you in your studies. Those can be found on my website, again, nexusnursinginstitute.com. Almost daily, you can find me covering a variety of nursing topics across my social media platforms, such as TikTok, Instagram, and Facebook. My handle is the same everywhere, Nexus Nursing. Without any further ado, guys, let's get started. Cushing's disease. Okay, first question. Select all that applies. Your patient's just been diagnosed with Cushing's disease. What clinical manifestations would you expect to assess in this patient? Remember, guys, how do we treat select all that apply? We treat them as true or false. Here's our choices: central obesity, thin extremities, hypotension, muscle hypertrophy, moon face, buffalo hump. What are the clinical manifestations? What are the signs and symptoms you would expect to see in a patient with Cushing's disease? Okay, so the correct answers are central obesity. So you'll see around the abdominal area, you'll see a large abdominal girth, right? They'll have central obesity, but even though their trunk is very, very large, you'll notice that the arms and legs are thin. They'll have thin extremities. They'll have a moon face where the face looks very swollen, very large, and buffalo hump where you'll see they'll have that hump, on the back of their neck. Now, let me explain those to you. The reason you see that is because, first of all, let's talk about Cushing's. With Cushing's, the patient's having excess adrenal hormone release, right? Patients secreting way too much cortisol. Remember, cortisol is responsible, plays a role in, blood pressure, glucose, the body's response to stress. But you got to remember that's also a type of what? It's steroid, right? And so what happens is that cortisol, it changes the fat distribution. And so that's why you'll see the patient have the truncal obesity, but they'll have the thin extremities. You'll see you'll see their face look swollen. You'll see they have what we call a buffalo hump, that extra fat padding behind their neck. Now, let's talk about the wrong answer choices. Hypotension, muscle hypertrophy. So you guys know I can't speak. Hypertrophy. I didn't say that right. Hypertrophy. Did I say that right? Anyway, you see it. You know what I'm talking about. So let's talk about why those are the wrong answer choices. So yesterday I was teaching you guys about Addison's disease, which is the opposite. The cortisol level is low, right? The adrenal glands are not secreting the hormones. With Addison's, you needed to add salt, add sex, add sugar, salt, mineral corticosteroids, sex, the androgen hormones, sugar, the glucocorticoids. Well, in Cushing's, it's the opposite. The patient has way too much salt, sex, sugar. They've got too much cortisol. They've got too much glucocorticoids, so the glucose is going to be increased. Too much mineral corticoids, so the sodium's increased, and too much androgens. Those are your sex hormones, right? So follow me with this. If we're dealing with Cushing's, patients got too much salt, too much sex, too much sugar, too much cortisol, right? Think about it. Too much salt, what follows salt? Fluid, right? So the patient with Cushing's has way too much fluid. They're actually holding on to all this salt. The salt's being reabsorbed, so they're holding on to all this fluid. What happens when the patient's holding on to all this fluid? You have all this fluid in the vessels. What does that cause? Hypertension. increased blood pressure. So you would expect this patient to have hypotension. If anything, we would expect their blood pressure to be high because of all the fluid that they're holding on to. Remember, what is blood pressure? Blood pressure is the force that's being exerted against the vessel walls. The more fluid you have within the vessel walls, the more force is going to be exerted. It makes sense. Now, what about the next one, muscle hypertrophy? Well, what happens with is in Cushing's, the patient has muscle wasting. We see what's known as catabolism, which the breakdown, we see a breakdown of those cells, and we see breakdown of the tissue, breakdown of muscle. So if anything, that patient has muscle wasting, not muscle hypertrophy, that word I can't pronounce, which means that word hypertrophy just means increased building up. The patient's not going to have increased building up of muscles. If anything, they're going to have muscle wasting when it comes to Cushing's. The patient tends to be very large. They tend to be overweight. Again, central obesity, but thin extremities, okay? How are you guys on the live? All right. Select all that applies. The patient with persistent cortisol excess is at risk for what? Here's your choices. Hyperglycemia, impaired wound healing, risk for infection, cachexia, anorexia, weight loss. In my explanation of Cushing's, I just answered this question, so you guys should all get this correctly. Is that proper English? You guys should all get this correctly. You guys should all get this correct. You know what I mean. So the patient with persistent cortisol excess is at risk for, select all that applies. The Kahoot code is 446-9401. All right, let's talk about this. Let me move this. The correct answer is hyperglycemia, poor wound healing, risk for infection. So let's talk about steroids in general. There are 4 things you guys got to know about steroids in general. Number 1, hyperglycemia, the sugary and make the glucose go up. 2, they mask the signs and symptoms of infection, puts the patient at risk for infection. 3, causes the bones to be porous. The patient can have osteoporosis. And 4, very hard on the stomach. Whenever you're giving steroids to a patient, you're always going to have them take the steroids with food because they're very hard on the stomach. But let's come back to what we're talking about here, the patient with persistent cortisol excess. This patient with Cushing's, we're going to see the blood sugar go up. We're going to see the patient have poor wound healing, and we're going to see the patient going to be at risk for infection. What we're not going to see is cachexia. That word cachexia, that's when the patient's wasting away. The patient with Cushing's, they don't look like they're wasting away. Remember, they've got that central obesity. They're large, they're heavy, they're holding on to all this fluid. They've got sodium retention, right? So they don't look cachexic. They're not experiencing anorexia or weight loss. If anything, we're seeing the opposite, okay? Select all that applies. You're providing dietary teaching to your patient with Cushing's. What should be included in the teaching? Select all that applies. Here's your choices. Are you going to teach them to increase protein? Are you going to teach them to increase calories? Are you going to teach them to reduce sodium? Are you going to teach them to restrict potassium? Are you going to teach them to reduce calories? Or are you going to teach them to reduce protein? This is select all that applies. So your patient has Cushing's. What are you going to be teaching this patient about their diet? All right, let's talk about these choices. You're going to teach them to increase protein. I just talked to you about how that patient experiences catabolism, how there's muscle wasting, right? So what does protein do? Protein actually helps build muscle. That patient needs to build muscle because they're experiencing muscle wasting. So we're going to tell them to increase protein. Absolutely. What about reduced sodium? Yes. Remember in Cushing's, they've got too much salt, too much sex, too much sugar. Salt is a sodium. They've got too much of it already. All of that sodium that's being retained is causing the fluid to be retained, which is causing hypertension and other issues. So yeah, reduce sodium, absolutely. And last, reduce calories. Remember that patient's heavy. They're holding on to all that weight. They've got the central obesity. So yes, we're going to teach them about reduction of calories and reduction of fat. Because remember, when it comes to cortisol, we have a problem also with fat redistribution, okay? What we're not going to teach them is to increase calories. They're already going to be heavy or overweight. We're not going to tell them to restrict potassium. Let's talk about potassium, guys. Remember, sodium and potassium has an inverse relationship. Where sodium is high, potassium is going to be low, and where potassium is high, sodium is going to be low. If in Cushing's, we know the sodium is high, we need to reduce sodium. What do you think is going on with the potassium? The potassium's low. If that patient has high sodium, their potassium is going to be low. So we're not going to tell them to restrict potassium. If anything, we're going to teach them about foods high in potassium, such as apricots, bananas, what's that other famous one they love to give you on NCLEX? Apricot, oh, potato. Potatoes are high in potassium. So you're going to teach your Cushing's patients about foods that are high in potassium because we know their potassium is low. And of course, we're not going to tell them to reduce protein. If anything, we want them to increase protein because we're trying to increase the muscle. Your patient just had a bilateral adrenalectomy. What would be your priority the first 24 hours post-op? So your patient just had an adrenalectomy. You got 2 adrenal glands. Both has been removed. The first 24 hours after surgery, what's going to be your priority? Here's your choices. Starting the patient on a soft diet, promoting independent ADLs, preventing adrenal crisis, or encouraging the patient to ambulate. Very good. Most of you guys got this correct. We're going to worry about preventing adrenal crisis. Whenever you get a test question asking you what the priority is, your priority is always going to be the answer choice that either keeps your patient alive the longest or can kill them the fastest. And when you look at these choices, by far, adrenal crisis will kill your patient the fastest. We're going to be worried about that patient going through vascular collapse, right? We're going to be worried about the blood pressure going down, the patient having hypotension, orthostatic hypotension, tachycardia, the patient going through arrhythmias, the patient going into shock, right? That's going to be our greatest concern, our priority concern with that first 24 hours after the patient has had both of those adrenal glands removed. We're going to be worried about adrenal crisis. For which symptom would you closely monitor the patient with Cushing syndrome? What would you be most concerned about your patient that has Cushing syndrome? Would it be hypoglycemia? Would it be hypokalemia? Would it be hyponatremia? Or would it be hypotension? I answered this already, guys, when I was explaining something else. Everyone should get this correct. Look at this patient with Cushing's. Look at that purple striae. Look how thin their skin is. Look, it's a female, but it's called hirsutism, where it's a female, but she'll have the male secondary sex characteristics, such as the mustache, such as the beard. Her voice may get deeper, right? This is what I call, remember how I said in Cushing's, the patient has too much salt, too much sex, too much sugar, too much salt. We talked about that, but too much sex. Those are your androgen hormones, those hormones that give you those sex characteristics. Okay. And of course, too much sugar, which is glucose. So anyway, back to this question. Our patient with Cushing syndrome, we're going to be concerned about hypokalemia. Guys, potassium is supposed to be 3.5 to 5. That is it. Potassium has a very narrow therapeutic range. Anything outside of that, the patient can have cardiac dysrhythmias. And we know that that patient that has Cushing's is going to be hypernatremic. They've got too much sodium, which means they'll be what? Hypokalemic. Not enough potassium. We're going to be concerned about that potassium level being less than 3.5. You guys following me on the live still? All right, very good. Once again, the code to get in is 446-9401. Select all that applies. I'm killing you guys with select all that applies tonight. Immediate after bilateral adrenalectomy, the patient's temperature is slightly elevated. The patient should be closely assessed for select all that applies. Here's your choices: dehydration, decreased lung expansion, sepsis, UTI, retained anesthesia, pain. So immediately after the patient had this invasive procedure, both of the adrenal glands have been removed. Immediately after, we're seeing a slight elevation in the patient's temperature. What do you think's happening? What are you going to be assessing them for? What could possibly be causing the slight elevation in temperature right after the bilateral adrenalectomy? Okay, let's talk about it. The correct answer: decreased lung expansion, retained anesthesia, and pain. So decreased lung expansion, this patient just had surgery. They're not, after surgery, you're supposed to turn, cough, deep breathe. You're supposed to get up and move around. All of that helps with the lung expansion. All of that helps with preventing upper respiratory infection. That's good, right? Here's the thing. Decreased lung expansion, that can cause a slight elevation in temperature immediately after surgery. What else? Retained anesthesia. And that makes sense. The patient's having retained anesthesia. Guess what? Most likely they're not going to be having that increased lung expansion, slight elevation in temp, and last, pain. Pain right after surgery can cause a slight elevation in temperature. Here's the thing, and I know what you're thinking. Okay, the number one sign of infection, or the earliest sign of infection that we usually see, is an elevated temperature. That is true. But follow me. Go back to the question that I asked. I said immediately after surgery. Immediately after surgery. Let me tell you something. If a patient has had surgery, oh, sorry guys. Not now. If a patient has had surgery, it takes time for us to see those signs and symptoms of infection, such as mucopurulent drainage, foul odor, warmth or heat at the site, elevated temperature. It takes a while for that to happen. We're going to see that usually after the first 12 hours because it takes a while for infection to develop. If we're seeing elevated temperature, I'm sorry, guys, I don't know why this keeps coming on, but if we're seeing elevated temperature immediately after surgery, most likely it's not infection. It's one of these: either decreased lung expansion, retained anesthesia, or pain. Your post-op, let me try removing this. Hold on, guys. Oh, sorry, guys. Give me a second. Okay. Your post-op patient's complaining of gas pain in the abdomen. What should you do? Insert a gas tube, insert an NG tube, encourage the patient to drink diet carbonated beverages, or encourage the patient to ambulate. Your post-op patient's complaining of gas pain in the abdomen. What are you going to encourage them to do, or what are you going to do? Very good. You're going to encourage the patient to ambulate. Think about it. Ambulation increases peristalsis. Peristalsis moves what? The gas. It moves all that air so the patient can pass flatus and they won't have that abdominal distension that's caused by the gas. Get them to move around. Look at the wrong choices. One person chose insert a gas tube. You want to know what a gas tube is? Nothing. I made that up. I made it up, okay? So we're not inserting no gas tube that Professor D made up in her head. Two people chose insert an NG tube. Let me tell you something. We insert NG tubes when we want to do what? Decompress the stomach, okay? If the patient's, NPO for an amount of time, we don't want them to get gastric ulcers. We want to decompress the stomach, then we're going to insert the NG tube. 3 people chose encourage the patient to drink diet carbonated beverages. And I chose diet in there to try to throw you off. I'm very proud of you. Only 3 people chose that. But what you want to do is get that patient moving around so we can expel all of the air out of their intestines. How are the adrenal glands affected by ketoconazole? Here's your choices. Ketoconazole suppresses adrenal steroid secretion. Ketoconazole destroys adrenal gland cells. Ketoconazole increases ACTH, or ketoconazole increases adrenal gland function. By the way, ACTH is adrenocorticotropic hormone. Very good. Very good. So let's talk about ketoconazole. The fact that you see it ends in azole, it tells you what? Most likely this is what? An antifungal agent. That is what ketoconazole is. It's an antifungal agent, but we only give this, guys, for very severe very severe very severe fungal infections. If it's like a mild fungal infection, we're not giving ketoconazole. We give that for severe fungal infections. Now, an adverse effect of this medication is that it suppresses adrenal steroid secretion. The good news is that once this medication is discontinued, the actions reverse. So the adrenal glands will start, working normally again. If it was working normally from before, it'll start secreting the adrenal hormones once that medication's been it's been discontinued. But while that patient's on the medication, an adverse effect is that the adrenal steroid secretion will be reduced or suppressed. How can the patient with Cushing's disease reduce bone resorption? Would it be increased potassium in the diet? Would it be to perform weight-bearing exercises? Would it be to reduce the intake of vitamin D? Or would it be to restrict the intake of calcium? Very good. Perform weight-bearing exercises. And I tricked 12 of you guys. So let's talk about the wrong answers and we'll get to the right answer. So 12 of you guys chose increased potassium in the diet. I've taught this to you guys so many times. Just because an answer is correct doesn't mean it's correct for your question. So yes, the patient with Cushing's disease, they do need to be taught about foods that are high in potassium, right? Yeah, right. Absolutely. But look at the question. I'm talking about bone resorption. By the way, guys, there's a difference between resorption and reabsorption. That one letter, the A, makes a big difference. So when we talk about bone resorption, that's to let go of. We're getting rid of the calcium in the bone, right? Bone reabsorption is to take back in. So there's a difference. The patient with Cushing's can have bone resorption, which can cause breakdown of the bone. It can cause osteoporosis. So how can we prevent this? By weight-bearing exercises. Let's still go on the wrong answer choices. Reducing vitamin D. No. If we want to decrease bone resorption, if anything, we're going to increase vitamin D because you need vitamin D to absorb calcium. So you're going to teach a patient to make sure they're ingesting enough calcium. And not only that, they need to be also taking vitamin D to absorb the calcium. So we're going to teach them to increase the intake of vitamin D, to increase the intake of calcium. So those two are wrong. Now let's get to the correct answer choice, which is perform weight-bearing exercises. Let me tell you what weight-bearing exercises does. By the way, weight-bearing exercises would be exercises such as walking, running, jogging, right? It's in the name, weight-bearing exercises. So let me tell you what weight-bearing exercises does. It pushes the calcium that was hanging out in the bloodstream, it pushes it back into the bone to make the bone stronger, right? That's why the patients who are at risk for bone resorption or they're at risk for osteoporosis, what do you teach them? You teach them to do weight-bearing exercises. You want to push the calcium that's hanging out in the bloodstream to go back into the bone to make the bone stronger. All right, guys, we're going to our last question. True or false? Bilateral adrenalectomy requires lifelong adrenal hormone replacement therapy. Is that true or is that false? By the way, you see these two pink thingies right here? These are your adrenal glands. They sit right on top of your kidneys. Very good. True. If you have a bilateral adrenalectomy, both of your adrenal glands have been removed. How are you going to get your adrenal hormones? They've been removed. You're going to have to get an exogenous source. You're going to have to get an outside source, or you're not going to survive very long, right? So a patient who's had both of the adrenal glands removed, they're going to need to get those adrenal hormone replacement medications for the rest of their lives. All right, let's see how you guys did.